change in the agenda. Mr. Whitaker is going to speak at 2, and then we will have a possible vote on the appointment of Karen Johnson. Sarah, we are live.
Thank you. Sarah Teachout. I'm the Director of Government and Media Relations for Blue Cross and Blue Shield of Vermont, and I believe I know everyone here. Lovely to see you all. And I brought a couple of documents to talk about briefly, and I know that I sent this one to everyone in the legislature, but you may not have had time to look at it. So I just wanted to start with saying that Blue Cross is the only, and some of this will be repetition for many of you, but Blue Cross and Blue Shield of Vermont is the only locally located health plan in the state of Vermont. We're not for profit. Right up the hill in Berlin. We have about 400 employees covering all kinds of jobs. We have a pretty big IT division, but we also employ doctors and nurses, lawyers, full finance team. So there's a whole variety of the type of people who work for our plan. So we are part of the Blue Cross and Blue Shield system. So this is what's a little bit unique about Blue Cross and Blue Shield of Vermont. Vermont only plan, but there are 34 companies, Blues companies nationally, and it works, I like to say, a little like a franchise. We all join together to offer coverage across the country. And we have essentially territories. So Blue Cross and Blue Shield of Vermont covers only Vermont. We can only sell insurance to individuals and businesses that are located here in the state. And we can only contract with providers who are in the state of Vermont and one county along all of our borders. So it's a little bit different than how other health plans operate, but it's really, things that are unique to the Blue system. And I think it's important to know that.
One county out of all the counties that are adjacent to our borders?
Oh, no. Around our borders, one county in.
Okay.
So in New Hampshire, we do one county in.
Okay.
They gotta be on the Connecticut.
And then just so you know, it doesn't work over water, so we don't do it over the lake into Champlain, over.
Look, Canada.
Anyway, I don't know, Blues rules. So,
I have to buy travel.
but
Drive real fast.
what we do have is an agreement among Blues plans that you can travel anywhere in the country and internationally, that any Blue plan has a direct, relationship with a provider, and you're considered in network. They process the claim for us, and then we reimburse that plan. And the same works for people from California traveling to Vermont with their Blue Cross coverage. So ski, we're a very mobile society, so it's important. And then the most recent change that's happened is that we became affiliated with Blue Cross and Blue Shield of Michigan last year, and that's unique and different. Up until then, we were a single state only plan with no special relationship with other Blue plans in the country. We are now a subsidiary of Blue Cross and Blue Shield of Michigan, just to be super clear, but we still operate and work just like an independent single state plan, because as you know, healthcare is really local. Healthcare laws are very unique to every state. And so we still really operate the same. What's different is, and the reason we did that is, we really need to be able to bring kind of all the back office operations that you don't see when you buy your health insurance plan to Vermont at a much bigger scale than we could ever achieve with our 228,000 members. So what it gives us is access to their IT systems, their software, their vendor relationships, all at a much, much bigger scale. And Blue Cross Blue Shield of Michigan has 5.1 million members and about 3,000 employees. So they are, in the scale of Vermont, very big. They're not the biggest Blue plan, but they're big. They are also nonprofit. That was really important when we joined with them. And they're a single state Blue plan as well. So they only operate in Michigan. Let's see. So I think I brought this up, and there were just a couple things I wanted to point out on it, and I wanted to make it big enough so you can see it, but Anyway, one of the things that is also unique about Blue Cross and Blue Shield of Vermont is this health plans offered box, which is kind of small and you might pass it up. We offer health plans in every marketplace in the state of Vermont. And so what I mean by that is we offer qualified health plans on the Affordable Care Act marketplace for individuals and small group. For large group, we do fully insured, self-funded plans. We also do federal employee plans. So that's a little bit unique to the Blues as well. We have the contract nationally for all federal employees. And so Blue Cross and Blue Shield of Vermont covers the federal employees who live and work in our state. And that's true for every Blue plan across the country. And then we do all the Medicare sort of commercial plans that people purchase. So Medicare Advantage, Medicare Supplement plans, Medicare Part D plans. So we offer insurance in every sector here in Vermont. Most markets have different competitors in every one. So, and that's partly because we don't have much scale. We can't offer insurance to someone not living in the state. So our market's pretty competitive. And then the only other thing I wanted to bring up on this chart, and we could talk about it, I guess, in depth later, is the for every dollar in premium. Here, I'll go back up. So we paid more than 1.5 billion. These are 2023 numbers, 2023. In a couple months, I'll have 2024. 1.5 billion for our members' care. I'm showing you the amount in that chart that is claims administration. So that's the cost of Blue Cross to administer your plan, and then taxes and fees that we pay to the federal and state government. So you can see here that the vast majority of the expenses we have for our members' care. And I should say right now that we are a very low cost health plan. The cost for us to administer our health insurance is 6.2% of all of the money we collect. So that's a very low cost health plan when you compare us to others nationally. And then the other piece that's really big here is that in 2023, for every dollar we collected in premiums, we actually paid out $1.11 in costs. So that's not what you want to do as a health plan, but that is what happened in 2023. And so we showed it here in this chart. So I think I was going to turn to take that and turn a little bit to costs, because that's clearly what this committee has been asking about in the healthcare system.
Before you go there,
Yeah.
where'd you get the extra 11 cents?
Yeah, perfect question. Thank you. I appreciate that. It came out of our reserves. So we are required by the Department of Financial Regulation to maintain reserves. There are members' money, paid it in claims. We maintain our reserves, and it's for instances when we can't cover the full cost of people's care. It's supposed to be, there's two reasons we have it. One is that nobody's perfect, and when our actuaries in the Green Mountain Care Board are setting the premium rates, and that's for the Affordable Care Act plans, but we also do it, for other plans. No one's perfect. So what you would expect is some years it'd be a little bit high, what we collect compared to what we pay out. Some years it'd be a little bit low. Over the course of a longer period of time, it would work out, but we have to hold those reserves so that we always have the money so we can pay claims. It's also for unusual and unanticipated circumstances like COVID.
I will leave it numbers.
Yeah. Another thing I just have to pull up is, I don't know if you all remember, it's a little bit ago, but when the Trump administration took over the first time, they stopped paying cost sharing reduction payments to health plans, but we were still required by Congress to offer those plans to our members. So we lost, I think, in the neighborhood of $12 million in 1 year on that one piece of federal legislation change. So there's all kinds of things that can come up that affect the finances of health insurance. So I think the other things here are pretty self-explanatory, and the team up at the office, who is much better at visuals than me, gave you a lot of pictures. But we do have the big numbers, about 228,000 members in our plans. the population on 640,000, and about 2/3 of that is coming from government sponsored plans. So we are the largest plan for the remaining sector. So I was going to turn to
Can I ask a quick question? Are you anticipating something similar might happen?
in 2024.
Yes,
Yes,
2025, I guess.
it'll be 2024, and then 2025 is different, we hope. So 2024, again, our health plans lost money overall, and I'll know the final numbers in March. I think March 1st is when we have to wait for the plan out, when claims come in and kind of do the final estimate. Let me step back. So when we file our rates with the Green Mountain Care Board, we have to be very explicit about what we're asking for our premiums for. So we put in all the details of what we expect the expenses will be for the healthcare costs for our members. So pharmacy claims, we also put in the risk of our population, the age, all those things go into what the actuaries are doing when they're asking for money. And then we also put in what we call a contribution to reserves. So we typically ask for 3%, and essentially that's our margin. So we're saying, this is what we think it's going to cost to cover the population's health insurance that are our members, and then we want a little bit extra for margin. And because medical inflation is growing far faster than 3%, that wouldn't seem like it should be enough. But what we do is we take the reserves that we already have and invest them. And if we can make a decent return on Wall Street, not every year, but over the course of those investments, we can offset what Vermonters should have to pay in to keep up with medical inflation. So that's why we target the 3%. Now back to your question. You asked for this year. Because of our financial situation, we asked that be increased from 3% to 7%. So we have asked for a 7% contribution to reserves for people purchasing our health insurance in 2026 to help refill our reserve.
That's your question about the Trump action from 8 years ago.
It's actually both. I am curious if that will happen again with the administration that just came in.
Yeah, no, it can't happen in exactly that same way because it actually turned out to be a policy when we, a year later, unmerged our marketplaces and did silver loading, that we're now actually drawing down more in federal funds than we would have under the original plan. So it's turned out to be better for Vermonters, but what's unknown is whether or not the Affordable Care Act advanced premium tax credits are going to continue beyond 2025. And that's where Congress needs to act. And it would be nice if they acted in a timely fashion so we could all make plans, but that hasn't been the way things have worked out. As of late.
So I remember there's so many people that depend on those right now. It wasn't overly popular to.
Yeah, we'll be talking to, so there are a lot of Vermonters who receive advanced premium tax credits,
Yes.
and it really lowers their cost to purchase health insurance on the exchange for individuals. And there's a bill coming to you. I know that we don't typically talk about House bills, but H35 would permanently unmerge those two markets. So going forward, we'd be in the same place as we are today.
We do know that bill is coming.
Okay, good. Excellent. So Blue Cross has strongly and supported that bill. It helps position us for whatever may come, but if the federal government stops the advanced premium tax credits, Vermonters are going to have really, really tough money. It's just not something that the state.
It's not just Vermonters.
Well, no,
Everyone
everyone across
across this country will have a really, and you get blacker than Texas already is in the slide we saw with the uninsured. It was just a dark hole,
right.
but
So
it will be darker.
yeah. So to jump back to why we had to ask for 7% this year, and it's because our reserve levels are now so low that we actually have less than a month in reserves, which is not good. And that happened for a number of different reasons, but in the course of the 5 of the last 6 years, we've lost money. And I mean, lost money, like Blue Cross is not trying to make money, but we've paid out more than we've taken in, right? For 5 of the last 6 years. Generally, the Green Mountain Care Board was underfunding premiums, which means they weren't giving us enough to cover our expenses. And then the second thing that's happened in the most recent few years is that they've tried to write that. So they've tried to say, okay, these are all the things that you expect as expenses, and we're going to give you enough premium to cover it. Then when hospitals go significantly over budget, I'm not talking a little over budget because everyone goes over and under a little bit, but when they're millions and millions, 100 million over budget, then our premiums definitely are not enough to cover the costs. And so then we dip into our reserves for that too. So that's been happening in the last few
And that's pharmaceuticals.
Pharmaceuticals are always a pressure, but so far they've been something with the exception of maybe GLP-1s and certain unusual ones, we are able to manage those a little bit better because we know what's coming. There haven't been as many surprises on the pharmacy costs. We just know what they are. They're going to be really high, and we build them into the rates. So everyone's talking, and I hear a lot of information about why healthcare costs are so high in Vermont. And I think I just wanted to talk through a few of those, and then I'll point to the chart. So one is demographics, and you heard from Robin and Brendan about that. We would say, yes, absolutely, Vermont has an aging population, but you have to remember, we also have one of the healthiest populations. And people, if you look at the numbers, it's people over 65 that's growing faster than the rest of our population. And that has some implications with making the commercial pool smaller, but it doesn't make the commercial pool more expensive because actually we only really cover people up to age 64. So that growth is happening in Medicare, but not on the commercial population. We've actually seen the average age of our membership drop recently. We think it could be the Medicaid redeterminations. Could be a little bit, maybe people moving into the state. There's not that many to make a big difference, but anyway, we're not 100% sure, but our demographics have actually improved, like on the commercial market. The other thing we hear about is that Medicare and Medicaid payments are too low. And so there's a cost shift over onto commercial. Certainly that happens. I would say that the Green Mountain Care Board has a lot of very interesting reports and presentations that were made to them about how many hospitals, and we have it for hospitals, not for independent practices, are able to break even or make some margin on Medicare across the country. And that's one measure of hospital efficiency. Our hospitals here in Vermont have not been able to break even on Medicare. And the other thing that we've done through the all-payer model is try to keep Medicare payments low since 2011. So we may be putting even more pressure on the commercial by participating in these federal programs. And then Medicaid payments in Vermont, I could send it to the committee. I didn't want to overload you with a million charts and graphs because I have a lot, but the Kaiser Family Foundation has a really interesting chart of Medicaid payments across this country, and Vermont actually pays really well on Medicaid. This legislature and AHS have done a really good job to try and increase those reimbursement rates for providers to help them with sustainability. So at least in Vermont, Medicaid isn't paying as low as it is in other states.
Yes, this morning, we heard we were losing community-based services, and because the Medicaid rates were not sustainable. So we're high, but
I'm sure everyone could always use more. The way that the Kaiser Family Foundation does it is they do it for primary care, they do it for hospital, and they do it for others. So you really should look at the breakdown because it's not across the board.
Can you send me that?
Yeah, I'll send it to the whole committee.
Yeah, I was just gonna add, sort of what Sarah just said, is that I think it depends on what Medicaid payments you're talking about. And what you're probably talking about are the healthcare covered that you cover. not the payments to other kinds of providers that wouldn't necessarily be covered by Blue Cross and other insurance.
I need to look, to be
Yeah.
honest, at what they've got in their data.
Yeah, I would like to look
I
at it.
can't answer that.
We could chat together.
I'm happy to do that.
Thank you.
So that I have also heard that we need more money in the system. We just all need to pay more. And I think that you and your constituents and your, families, employers will tell you we are paying more, at least on the commercial side, than almost every other state in the country. So paying more really can't be our answer here. And we ranked number 1 this year, and I have it on this other handout that I'll be able to pull up in a minute when I figure it out. But we ranked number 1 in the country for healthcare costs last year, which is not a great place to be. On the top side, we want that for access and quality and all the other things. Another thing that I've heard about is that Blue Cross is not being well run or well managed. Just to address it straight up, that is not true. We have some of the lowest administrative costs in the country. We're very well managed by like the typical measures of how a plan operates.
I'd say if we cut out all your administrative
Yeah.
costs, it wouldn't
You're still in the
make
one.
a whole lot of difference.
It doesn't. And to be to just tell you, we have been cutting our administrative costs. We can't cut a whole lot because we still have to, offer all
We
the services.
would
our
like you
clients
to
need.
be well administered.
But we are doing what we can to cut back on our administrative expenses.
Let me ask you a question.
Sure.
I heard you just say that Vermont has the highest health insurance in the nation, highest, most expensive.
Yes.
My question to you is, can you point to things that this legislature and our predecessors have done over the last 20 years that would be a direct line to driving up those expenses?
I could point to some for sure. But those won't be the only things. There's a lot of pressures, but there's certainly been decisions made here that increase costs.
I would love that list of things that you would identify as things that this legislature has chosen for the healthcare system in the state of Vermont that have led us to be the most expensive private health insurance market.
Just from my experience at EndCoil with other legislatures, we tend to start with what we think people should have, and they start with how much money they think they should spend. It's some states did not do the Medicaid expansion, so if you are working for minimum wage, you don't have health care in those states. And we have had to find effort to make sure that you do have access to health care. But it adds up. But
Well, I think also the issues about states, how they define healthcare. We add a bunch of things to healthcare that some other states don't. Other states don't, and many states don't have coverage for naturopaths, for example, and other kinds of medicine. Many states don't impose specific standards or dollar signs for the amount that can be done for a particular procedure, but we do quite often. So I think that one of the reasons I would suspect that our costs are higher is because we have more things that we authorize to be paid.
it's
That's a conversation I welcome because I feel like our voters, our constituents are asking us to have that conversation.
we had quite a few afternoons on the copay for chiropractors in this committee. It was unbelievable. It is very hard to cut something once you've done it. But we have done it.
Thank you. Couple questions. So yes, I heard you say that we're number 1 for healthcare costs, and I'm wondering if you might be able to get us data as to
Yeah.
what the impact of Medicaid is on that.
Oh, okay. But yeah, so this is the one I'm citing. It's Consumer Affairs, January 9th, 2025. So it's this link right here. There's lots of data sources, but that's the one we used for this.
And my follow-up is, we kind of got to this in the last presentation, but I guess I'm interested in teasing it out a little bit more. I think we're making the assumption here, maybe, that fewer people or fewer services that are covered under insurance equals less cost. And I guess I want to know if that's true. Because my sense is that when folks are not insured and they don't get care early on in their illness or whatnot, they end up actually driving costs up by showing up at the emergency room. And then by that point, they need really invasive procedures that are more expensive. So I don't know if that can be quantified, but I'm wondering if.
Yeah, I mean, that's absolutely true. We all know that. I'm not sure if it can be quantified, but I can look around. The other thing is, I mean, costs are three things, right? It's price times utilization, and also the type of utilization. So how intense the services are. So if we got, everyone just going to see their primary care and they're not using very much more, they could go to a lot more visits and that still wouldn't drive up the cost. But we have, the other thing that we have here in Vermont, I think it's pretty broadly recognized, is that more care is being delivered in the hospital setting that could be given somewhere else. So that's another thing. So we have high prices for our hospitals and then more care happening in the hospital setting. So that's kind of two things driving up costs.
Okay, Scott.
So community hospital, that's like NVRH or, and then freestanding facility would be,
We only have we have maybe two. It's the one up in Chittenden County.
okay, yeah.
We have an I one too.
Private medical provider, specializing broadly.
Right, there's the one in Colchester, Green Mountain Surgery Center.
Okay.
Yeah,
Oh,
surgical
right.
center.
Yeah.
Yeah.
Got two.
So I'll send this to everyone in the legislature again. What we're really trying to do is just provide snapshots of information that we hope will be more useful than, we have in the past. So this is all self-selected information
Do you have a question?
about costs. Yeah. I'm sorry.
No, that's okay. Got it.
And I wasn't going to read the whole thing for you, but we thought it would be helpful to show you for some very common services, the differences in price. At the university, and this is now all because of the transparency laws, all this stuff is available online. And this is for Blue Cross and Blue Shield of Vermont members. I could give you the zillions of caveats as to how we chose the number, but we were consistent in what the services are. But so we show you for MRIs, the difference between UVM, Dartmouth, a community hospital, which we've averaged across all of Vermont community hospitals, and then freestanding facilities. There is open MRI, so that's really the freestanding facility for MRIs here in Vermont. We made an announcement last year that we were eliminating prior auths if you went to open MRI because we were trying to direct people to lower cost sites of care. So I've just given you for some common things. These aren't complicated, I'm sure you could say, oh, there's a lot of variation in healthcare, but this is meant to be consistent.
Would you reflect on the notion of reference-based pricing as to how that would be overlaid with what I'm seeing here, just the general topic that's percolating from the auditor's office and elsewhere?
Yeah, so reference-based pricing would be a way to kind of rationalize some of this, because the Green Mountain Care Board or whoever you choose would set a price for a service. So I'm going to do colonoscopy because it's a little bit easier, and they would say, we'll pick the middle price, $2,500 for a colonoscopy, no matter where you go. Or they could actually say it might be more at a hospital and less at a freestanding center. There's different ways they could do it. But they would say that's the price. And then the provider could decide we're going to offer it for that price. We're going to be more efficient in the way we do services. But there wouldn't be this variation across providers that you see right now. So that would certainly, it depends on the price they pick, but if they picked lower prices, it would certainly save money. The only thing I want to say about the reference-based pricing is often a percent of Medicare. It's fine, you can reference off any number you want, or you can set it as your own number. The only thing that we feel strongly about Blue Cross as an organization is that we don't pick and do it just for one payer. So, or one employer. So if you just do it for the state of Vermont employees, or you just do it for the Beehive Trust Fund, those costs are going to come out on the rest of the commercial marketplace. And that's, we're very concerned because we cover everyone paying for insurance. So we're supportive of the concept, but we really want it to be broadly applicable.
And the other issue would be the impact on hospitals' budgets,
Clearly.
and whether or not it would get cost shifted on to whoever wasn't covered, or put some of our hospitals that are in the red belly up. So, because we're essentially taking money out of the system.
For us and hospitals, we would never recommend doing it flash overnight. We definitely think you would want to phase it in, both in the percentage or the reference that you're doing, but also the services you're doing. I don't think this is the kind of thing we could do overnight, reference-based pricing for every single thing we pay for. You'd probably want to phase it in by kinds of services.
So I'm really intrigued by this subject, and
Yeah.
what I understand of the Green Care Board discussions and capping the total revenue from the hospital, that seems counterintuitive to me to what we want to achieve, because then you're motivated to extract or achieve or offer the most return or both richest margin services. Whereas reference-based pricing, if I'm a hospital, then I'm motivated to achieve more greater economies of scale, or I want to provide more with lower administrative expenses. So I'd be really, with your Blue Cross Blue Shield network, and that this has been done in other states, I would welcome how this worked in Montana or elsewhere, and how this might actually look. I know there's a bill coming, but it seems like there's fruit to bear from this discussion tree.
Yeah, I think Blue Cross and Blue Shield of Vermont would agree. It's a good thing to pursue, and the total cost of care is kind of the or global hospital budget is this big picture number, and this would provide some structure within the pricing system to achieve that total number that they're going for. And like I said, there's just also some rationalization about this for consumers. Like, they would understand more what the price is instead of not knowing what the price is for where they go. And I would echo everything that Robin said about people using the cost tool. We have a cost tool on our website. I'm not sure if it's operational right now. We didn't get a whole lot of complaints about it not being operational because it's rarely used. People really don't shop.
When you're sick, you go where your doctor sends you.
Right. And, the only way it could be useful is for things that you go, your mammogram or your colonoscopy or your MRI, if it's not an emergency. Those are really the ways that you may be able to use it, but people are, reluctant to drive far for care, and they're reluctant to go somewhere that their provider hasn't recommended or isn't, part of the provider's network. So it's not something that's common. So I didn't want to take up a whole lot more of your time. I can send this to you and you can look at
You
it.
will talk more. I was feeling the hospitals may have a different way of that experience.
Well, thank you for your time, and I look forward to working with you all this year.
Thank you. You might see more of you. All right. Mike, show me what
Good afternoon. I guess I get to sweep at the end of the day. Were we talking about not doing healthcare last thing of the day?
health insurance overview
Health insurance.
on Friday at 3 o'clock.
Yes, so I am Mike Fisher. I am the healthcare advocate, and I have not come with a presentation or particular talking about a few points I want to make, a particular script, which means I'm sure to get myself in trouble.
I do that all the time.
First, just very briefly, I think most everyone knows this, but I think I just need to say it. The Healthcare Advocate's Office is a position. The chief healthcare advocate is a position in the office, is defined in statute, and through a RFP process, landed at Vermont Legal Aid in 1999 and has been there ever since. And I've been in this role since 17. I think. We have two major parts of our office. One part of our office is a helpline. We have 8 lay advocates every day, working with people who are having some kind of problem with some part of the system that's not working for them. And then we have a policy team that has this ominous task of representing Vermonters' interests in front of every place that healthcare is being discussed and decided upon. Around state government, we care board, and even the private entities. We do our best to be a part of the decision making. We're at our best when our policy team and our advocacy team are informed by each other. And so cases come in the door, people raise concerns, we try and use that to inform what we have to say. The HCA, as a part of that representing Vermonters, we're in front of the Green Mountain Care Board every time they meet. We're there every time they meet, but we have a particular role in insurance rate review. And so we've got 2 attorneys who argue on behalf of Vermonters at each qualified health plan rate hearing. Also the large group, so in the fully regulated market. And you know what we have to say shouldn't surprise anybody. It's pretty predictable. Vermonters can't afford it. This rate increase will price more Vermonters out of the ability to afford the care or the privilege they need. That's, you know, and we do our best to present evidence. I meant to bring my computer. I wanted to show a chart. I'll show it later. When you compare the rate of increase in premiums to real Vermont wages, it's a stark comparison. You know, the costs of premiums not even accounting for out-of-pocket costs as compared to wages is, you know, one line goes like that, and the other one goes barely climbs in comparison. So in a real way, I'm not surprised by what we're seeing today. I think I'll just say part of my job, I think today is to, in a little bit more urgent way, wave the flag of the crisis we're in, and to state it more clearly from where we see it. Everywhere we turn and look around our healthcare system, we see tremendous vulnerability. Can Vermont businesses afford another 20% rate increase this next year? I don't think so. Is there, you know, it's been reference to the number of hospitals that are at risk. Boy, you look around at other parts of the healthcare system, the FQHCs, we're at real risk. To some degree, and let me just mention Blue Cross. I appreciate Blue Cross's presentation just now. And I do want to recognize a few communications from Blue Cross. Last week, maybe, we received an email from Don George quantifying some of the recent losses. And one detail that Don George recognized was that at least in 1 month, it lost $13 million. The claims were $13 million more than the premiums paid. So, and I'm aware that trend has been for a number of months at the end of a number of months in 2024. I want to recognize that Blue Cross is doing a lot to stabilize itself, and that, but I also want to recognize the low risk there. The Hammery report that happened this past summer and fall, the Act 167 process. The big takeaway I had from that is hey, if we keep doing the same thing we're doing without intervention, we're gonna see hospitals close. I'm pretty frustrated that, after that report, there was, a response from the industry was to attack the messenger and attack the report as having, the data was wrong. They brought up, details in there. I'm sure there are important details to them, but none of that pushback changed the overall message. And in fact, I think confused us from the overall message. If we keep doing what we're doing now without intervention, the market's going to take apart key parts of our healthcare industry, healthcare infrastructure, and man, key parts of what keeps our individual communities healthy. And so maybe I'll just fast forward to that main takeaway of this moment. We have to have a theory, including the tax rating committee. We have to have a theory of how we're going to pay for the system we have. And it's not even like that we need more money. When I hear about hospitals that are losing their days cash on hand and insurance companies that are losing their reserves, real statement is we're not paying today. We're not paying for the healthcare system we have. And, as the healthcare advocate, I should be sitting in front of you saying, we need the very best system in every community. People should be able to get the care they need without having to drive far. And I believe that. But my fear is that if we don't, and I don't want to see hospitals repurposed or purposes changed and reductions in services in one community or another. But even more so, I don't want to see a lack of action and the marketplace closing those same hospitals. I'd rather see a planful approach.
So I would really respect and appreciate your opinion. I've been hearing from lots of individuals and I haven't heard anybody yet make the case why we shouldn't raise the threshold for the certificate of need trigger to more competition in the marketplace. Who would be against that occurring?
I think that there's all kinds of implications of what you just said. I'm going to stick with the main push. I think there's broad support for raising the threshold for where it should be a certificate of need review. I think because there's a recognition that the administrative effort of CON is not worth it. We don't get it. We expend more than the value of that review. From my perspective, as someone who's there to fight against bad stuff in the system, you're going to hear me say, hey, heads up, there are bad actors that want to take advantage of, they want to make money and take advantage of Vermonters. And we need some kind of, I don't want to do away with this need system. We want to make sure that there is still a level of review and decision making. But there's another implication, there's another thing you just said, Senator, and that's create more competition. And
More options.
Okay, more options is a different statement. For sure, well, I'll just say when the Green Mountain Surgery Center, a lot of years ago now, went through the CON process and it took a long time. At the end of the day, the Healthcare Advocates Office supported it. A lot of local hospitals did not and pushed back hard on it.
It was heavily debated here.
But at the end of the day, we supported it because we didn't believe it represented as much destabilization as the hospitals argued. And we believed it gave Vermonters a lower cost option. And so, there's a couple,
Well, I was just gonna say that there are, I I'm co-sponsoring a bill that would raise the thresholds on the CON, and I agree with what Mike said, that they're too low right now and haven't kept up with the inflationary costs. But there is value in having a review of new, bricks and mortar and high expensive equipment. And, part of it is if you remember from Robin's slide, the use of technology is one of the driving costs in American healthcare. So if we don't have some kind of check on the, newest fanciest thing, then that could drive the cost potentially. There are also quality issues and placement issues in terms of where you site things and how they might compete with local community hospitals, et cetera. So there is some value to having that kind of review, and there is more to it than just the cost threshold. There's the CON process is more than about just the cost. So I think that, don't throw the baby out with the bathwater. There's some value to it. It's just that what we have right now hasn't kept up with the times. And also the profit motivation in American healthcare can be super damaging. And as Mike said, there can be like bad actors that come in and try to, sell healthcare services that are not necessarily helping or of good quality.
We had a rather robust discussion about birthing centers. And that's fine, but OBGYN is expensive because you have to have someone on call 24/7. A birthing center is fine for a normal birth. But if there's no hospital and they're closing them, Springfield's closing them because of the expense. If you have a birthing center, that's great, but what happens when there is a problem delivery? How far in the middle of a snowstorm can you safely, and how do you work that out? Chittenden County's got a certain population. Central Vermont's got some choice, but a lot of Vermont believe you now have to go to Dartmouth for chemo or infusion chemo from the kingdom. That's a long drive when you're suffering the after effects of chemo. But there's no place up there that does enough that feels they can afford to do it. So it, again, is a real balancing act, and what Chittenden County could support the separate surgery center. And I was on health and welfare, and it was funny there. Maybe central Vermont, but probably not any of the more rural areas, because there just wouldn't be enough surgeries to support two centers.
You're saying there needs to be nuance for the certificate of need.
Yeah.
Is there not some nuance now for the?
Well,
beginning question?
I don't know.
There is nuance,
Yeah.
and that's what I was saying, don't throw out the baby with the bathwater kind of concept. Is that, I think there definitely is time for tweaks, but it's not something to say, oh, we shouldn't do this. There are ways to make it better and more effective.
Yeah.
But doing away with it entirely, I think would be safe.
When Ishka was doing healthcare regulation, the idea was if we bought an MRI machine, once you paid for that machine with visits, it was gravy. And the theory was you would refer more people to get an MRI when maybe it would be just health effective to do an X-ray, which is where some of the prior approval things came in. But that was the, or I can remember hospitals just want to create palaces. I remember, I think it was the chair of this committee that said that frequently, not this one. But the idea was that you didn't, and build new steel glass, you keep the old brick one, and retrofit. So it's been controversial.
Just like to share kind of a background information that I have on this. I've always been astounded by healthcare and how its cost for everything continues to rise. But every time I go into Best Buy and look at the new TV sets and video recorders, the price is lower than it was the last time that I was in. And you almost see that with every area of technology. You realize it costs less now in inflation-adjusted dollars to send a rocket into space than it does to get a colonoscopy. The inflation-adjusted increase in healthcare is almost unique. And that, I think, is something that deserves a lot more study and analysis as to why.
Because they can.
Yeah, and I don't know the answer to that question.
Well, if you're sick, you pay the cost.
Well, indeed, I mean, it's a little bit to do with the slide that Robin had up a little while ago about sort of the complexity of this marketplace. And I think also getting healthcare is, and then our motivations around getting healthcare are a different dynamic than our motivations around getting a TV. And
A neighbor of mine makes high precision medical equipment at a factory in Swanton. I remember him testifying before one of our committees, so it's got to be 10 or 15 years ago. And his testimony was, you see this little piece of device right here?
remember this testimony.
You remember that? And he said, this device I make for 7 cents, but put into a patient at Dartmouth, it costs $3,000. Why?
Same exact.
Same exact device.
Hospitals in, because I'm sure they have an answer for that.
Oh, we will have the hospitals in before.
So if you look at it, and again, this is one of the things that I don't know how well the job everybody here does. I mean, somebody theoretically does it, but of looking at the whole cost structure and particularly the elements of it, because it's so layered in terms of the participants. You certainly, have the concerns about the pharmacy benefit managers and that process, for example, of the number of middlemen who are involved in taking a slice out of something. And that is only a small piece of it. But just analyzing costs at various levels makes me, frankly, as I'm very, very suspicious of it.
Well, so maybe this is close to reference-based pricing.
Yeah.
And this is close to reference-based pricing, I'm just saying. And let me just say, I am supportive of the effort to move towards reference-based pricing. I have similar concerns that Blue Cross just mentioned about doing the segment of the marketplace. I think we could try to make sure that the costs don't balloon out to other parts of the marketplace, but I think it would be a try to. I'm not sure. I would have a hard time being assured. And further, yes, the taxpayer is really harmed by the cost of public employees. But the small business person is equally harmed today. And I think the prospect, I'm not going to commit myself to this because I think it's possible that the right thing to do is a segmented move towards universal, a full reference-based pricing. But I just know that if you put in front of us, if the legislature moved forward on reference-based pricing for public employees and didn't touch the small employer world, you hear a lot of frustration.
There will be cautious.
I also I want to recognize a couple of other moving pieces. You do have a decision in front of you this year that needs to be made this year and rather quickly about merged or unmerged individual and small group. I was trying to remember how long ago it was that happened, and
Was it 2 or
3 years
it
ago.
was in 21 or 22.
we did
Yeah.
it 1 year for a year. And then because it was gonna run, it was only 1 year increase in the federal subsidies. And then they extended it for 3 years, 3 or 4, and we extended it
So in
But that's-
21,
running
in
out.
at this table, I delivered a letter saying, I think we should look at this. And your committee moved in doing a 1 year.
Should we say before that you had adamantly opposed?
So, yes, thank you. I want to recognize my position on this has changed.
No, but this was before the subsidies.
It was the enhanced premium tax credits that made us say, this doesn't make sense anymore. And so that will come to you, and newsflash, I'm gonna be consistent at least this time. I think for a number of reasons, and maybe I can do it more later. I think it makes sense to continue with the unmerged position. Largely because of the structure and the way the Affordable Care Act works, and because of something that I'll just give you a preview of today. Silver loading, the Vermont strategy on silver loading really worked this year. The Green Mountain Care Board's actuary estimated that it was worth $40 million in increased buying power for people in the individual market. I don't know if that's exactly right, but whatever the number is a increase in subsidy for Vermont, lower income Vermonters to buy better quality plans without a need for a state match. And so I think given silver loading in particular, the HCA will support maintaining an unmerged market
Washington doesn't mess it up.
until messes it up. Then lastly, I think I do have to mention that, and maybe this goes back to reference based, the prices of our system are out of whack. And yes, our demographics are a part of it, but you know what, Maine is open to this. And there are many different reasons for this. It's not simply one thing or another. But the bottom line is Vermont's prices are out of whack, and it will be painful to right price our healthcare system. So not any illusion that this is some kind of simple fix out there.
We're gonna find out how the pain threshold on this committee is between this and education.
But let me just say, if someone could deliver to me a theory of how we're gonna pay for it, I'm on board, and I want to figure out another way to not have to live through the pain of affecting our prices.
Yeah.
Somebody, if the hospitals came forward and said, you know what, this is important enough, we think there should be an increase in a broad-based tax in order to pay for it. I might think you're politically not reading the tea leaves, but at least we would be saying we have a theory of how we want to pay for it. Short of that, I think we're driving off a cliff, and we need to pump the brakes.
Education. I may find the money to pay for this year's increase, but if I can't bend the increase curve, the money I find this year is just going to be gone this year, and it's bending. We've got to bend the curve. We aren't getting that much better health care for that much more cost. We won't even talk about pharmaceuticals, which is, I don't know if it's the first or second. I think it's the second now. Leading cost driver for healthcare. And we spent 3-4 years almost totally focused on pharmaceuticals. And we have not bent the curve. And you go, how far is it? 60 miles north, I think. And the pharmaceuticals are less than half the price they are here. And they're perfectly good pharmaceuticals. The same ones.
Part of the problem with the pharmaceuticals is that they are federal
Yes.
regulated for the most part, and Vermont state legislators have very little impact on them. And we have just this system that is completely based on profit of pharmaceutical companies, and that is the number one thing that drives up pharmacy costs in the United
Been
States.
told they are the largest donor to political campaigns in the country.
And I understand the effort to negotiate those prices is.
Just been, yes.
New roadblock.
Yeah, yeah. I mean, finally, last year said Medicare could negotiate to the prices. Before that, Medicare was banned.
Yeah.
I'm
And
not
it
sure
was
that,
just revoked yesterday.
Oh, it was revoked yesterday?
So,
Oh, well. I have the email address for Canadian Pharmacy. The $200 a week prescription cost $44.75. And that includes shipping from Mauritania, which is where all the name brand years are also made. But that's the,
But
and
there's
that's
also
a 90
substantial
day,
fraud
that's
in
90
many
days.
cases in those Canadian mail order pharmacies that we've seen in the past, that things aren't always what they're reported to be because they're not looked at by the Canadian authorities. This is a company, so this is something that we do have to be aware of. Now, I know we used to have situations in which we had buses,
Yes, we did.
from St. Albans that would go up across the border to Montreal, the pharmacy. I bought Canadian, I've had products in past years, I don't now. I remember one thing I had was a tablet that cost $62 to purchase each one in the United States, and I got it in Montreal at a pharmacy for less than $10. And the only thing I had to do was go see a Canadian physician, and their storefront physicians that you can go to get the prescription the same day. So it wasn't hard to do, but you just have to go across the border
Yeah.
to do it.
I mean, but it is that big a difference, and I haven't heard the Canadians were up there as having better outcomes and lower costs than we do. I haven't heard of my grandchildren being bad drugs.
I mean, it is useful right now for people here in the States that if you have a particular prescription, it's a high value prescription, just go online and see what you can get at a pharmacy in Montreal, as opposed to the mail order pharmacies in foreign countries that some of the mail
Well, this
order
is
providers
Canada.
offer.
This is the Canadian.
that's this-
pharmacy.
Yeah, but they call themselves that, but
Well,
the question is, are you getting
Cardiologist, this is
know,
the
and-
number.
in a place that you can rely on what you're getting?
So we will, but those are the two big cost drivers, hospitals and pharmaceuticals. We have had, I think, almost no effect in controlling the cost. We also don't have any manufacturers. We have very little hook in that market.
Well, it's also difficult here to get effective pricing for pharmacy. I know we have disclosure requirements regarding certain drugs and so on, but it's not easy to get that from pharmacies. They're not that forthcoming. You have to have a prescription in some pharmacies, like Walgreens, for example, in order to ask what the price would be for it. They won't do it, or give it to you unless you have a prescription. And I know the law may not specify that that's the case, but that's the practical use of it. So there are roadblocks. It's not easy.
They have to tell you if you could get it full price cheaper. We did that. Some things you can. Okay, we have one more.
Madam Chair, it's always an adventure to sit in front of this committee. Thank you for the time, and I'm happy to chat with any individual members or back before the committee.
Thank you. Maybe we will, when we get to this, we can't do Freud with healthcare because it's in the morning. But these are issues we're gonna be working on with them and try to get this through. We've one witness left, not last, but definitely not least, which is our second major provider on the market, MVP, and Jordan Esty is with us. So Jordan, welcome, and the floor is yours. Just
Great. Thank you, Chair Cummings and members of the committee. Can you hear me all right?
Yeah.
So after a great discussion, and I'll keep this brief, but I did want to share a couple of slides because I think it's helpful just to, quickly paint a picture of who MVP is as it relates to Vermont's health insurance markets and our role in them. So bear with me for 1 minute. Okay. You see my screen all right?
Yes, perfect.
So very quickly, just to contrast a little bit with what Sarah presented about Blue Cross Blue Shield of Vermont, MVP, like Blue Cross, is a small regional not-for-profit health plan. Our footprint extends all of upstate New York and Vermont, so we're only in those two states. But we've got about 600,000 members. The bulk of our membership is in New York State, and New York has a different set of rules around its Medicaid program. So we are very heavily involved in partnering with the state to deliver, their Medicaid, their child health insurance program, and their state-funded safety net programs. But we're also in commercial markets, the exchange markets, fully insured large group, self-funded. And in Vermont, as I'm going to cover on the next slide, our membership is really only in the individual and small group markets. So those markets, you purchase coverage, whether you're a small employer or an individual, through the state's health insurance exchange. We've been in Vermont since 1993, licensed as an HMO. We've got about 30,000 members in those two markets in Vermont. So a very small slice of our total membership of 600,000, but a significant presence in those markets there in Vermont. Very robust and comprehensive provider network across New York and Vermont, with more, we were contracted and partnered with more than 5,000 local providers. And as a community-based, mission-driven organization, we take very seriously our role in the community, in being a partner to providers, community organizations, policymakers like yourselves, in terms of, being at the table, being part of the solution, and doing what we can to deliver, affordable, high-quality healthcare to not only our members, but the entire communities that we represent. This is just reflecting, where MVP's market share is. Now, Chair Cummings, you mentioned the MVP being the second kind of major player, and that's true as it relates to the state, what I would call the state-regulated health insurance markets, which are individual, small group, and fully insured large group. There's about 72,000 members in the individual small group markets. We've got about 38 to 40% of those members. And again, that is really where our Vermont membership is. So we're a small participant in the grand scheme of all of Vermont and where, Vermonters get their health insurance coverage. But, I think a very, relevant and important plan as it relates to the state regulated markets and a lot of the policy discussions that you all have. These slides I had actually prepared for kind of an introductory overview of MVP to the House Healthcare Committee last week, and I had pulled these two graphs in particular. And after listening to the conversation, just now, I think they're really important and certainly in line with a lot of the questions and what some of the other presenters had said. I'll start on the right-hand side, because there's been a lot of discussion about cost and where Vermont is relative to other states in terms of the affordability of health insurance coverage here. And what this slide shows is in the QHP markets, individual, small group, state regulated markets through the exchange, premiums have been increasing everywhere across the state, but they've been increasing in Vermont at a greater level. And they're starting at a greater level in Vermont. So that's, simply not sustainable. And, as Mike had shared, small employers in particular, individuals and families purchasing coverage in these markets are, they can least afford the dramatic cost increases they're seeing every year. On the left-hand side, this is data I had pulled from an overview of the health insurance markets that Nolan Langwell had given the legislature at the beginning of last session. The data only runs through 2020, but this trend, has not reversed. So what you see here is a change in enrollment between state-regulated commercial markets and non-state regulated commercial markets. So your self-funded ERISA plans, federally funded markets, or federally regulated markets, and then your fully insured state markets. And what you see here is that there's been a significant decline in the number of enrollees in the state's fully insured markets and a big increase in the non-state regulated markets. So, as we talk about cost, part of the issue here is, we've got a small and shrinking pool of Vermonters that are in these state regulated markets, and that, increases the volatility, of the market. The members tend to be, sicker on average, and it tends to result in higher cost pressures and volatility. And I'll just point out, if you're not aware, in these state regulated markets, particularly the exchange markets, there are only two carriers. So it's Blue Cross Blue Shield and MVP. Cigna has a small presence in the large group markets as well, but really two carriers in, these focal points of state insurance regulation are MVP and Blue Cross. I'll
Just a
just,
question about that slide.
yes.
If you go back, can you bring the slide back? I'm looking at the two different categories. The last one that showed state regulated versus non-state regulated. I just want try to get a little clarity on the non-state regulated. Are those employees who live in Vermont who are employees of businesses that are multi-state businesses, or is there anything else besides that?
Yeah, it could be association arrangements. There's innovative captive arrangements, my understanding, in the health insurance space. But generally speaking, this is going to be your what we call self-funded market. So the employer is bearing the risk in those arrangements. They're paying the cost, and then they're partnering with a health plan like MVP, like Blue Cross, like United, like whomever, to act as a third-party administrator where we are, we're maintaining the network, we're processing the claims, but the financial risk actually sits with the employers in those arrangements. Now, I will point out, this is not a uniquely Vermont trend. This is something that's happening across the country, but given the higher premiums in Vermont, I think it's particularly acute here in that, I think part of the reason this shift is happening is you've got employers that are just, struggling with the burden of health insurance premiums and looking for more affordable, more flexible options to offer their workers, if they can afford to offer coverages at all. I mean, that's certainly a piece of the challenge here as well. Any other questions on this before I move on?
Yeah, I have one more question.
And to your point, so those employers can set health standards for their employees, like they can have no smoking policies. And so you're saying that more of the riskier type or the more expensive to insure are getting shifted to the state regulated market, while those ERISA
remaining in that market, right? Versus, those that there are affordable options elsewhere because they've got a healthier workforce. They can, their claims experience is going to be better than the overall risk that's shared in the state fully insured market. So it's a more affordable option for a lot of employers, and that's happening nationally, and it's certainly happening here in Vermont. So why I wanted to raise this, because I think it's an important policy variable to really understand. And I had shared this again with House Healthcare, a couple of policy principles we have that we would kind of urge the policymakers of Vermont to be mindful of. The first is, again, it's protecting Vermonters against unaffordable, unsustainable healthcare costs. Been a lot of good discussion today, a lot of good questions from the committee members. Health insurance premiums are expensive because healthcare costs are expensive. I always tell people that we don't want to raise premiums any more than we have to, right? The reality is we have to, but we have to charge premiums that cover cost. And in the case of a not-for-profit like MVP or Blue Cross, when we're profitable, that's not profit that's going to, benefit shareholders. It's being reinvested in the business. So, we have to charge premiums to cover costs, but regretfully, costs are simply, they're uncontrollable year over year, and it's putting us in a position of having to raise premiums to levels that we don't want to, and most importantly, to levels that Vermonters in these markets, small businesses, families simply can't afford. Number two, and this is really kind of a general statement, but we would urge policymakers to really put individual Vermonters at the center of all of these discussions. I think, the healthcare system's changing, it's changing rapidly. And, as we think about a future state and a healthcare system that's equitable, affordable, resilient, and transparent, that is really built around Vermonters' individual healthcare needs and experience. There's a lot of technological advancements, a lot of opportunity, I think, to just move away from a healthcare system that has traditionally been very siloed, but very fractured, right? You've got your hospitals, you've got your pharmacies, you've got your health plans, and all of these stakeholders that aren't really integrated in a meaningful way. I mean, again, not just the Vermont challenge, but the historical kind of nature of the U.S. healthcare system is it's not really built around the patient and their need. So, I would urge policymakers to really, prioritize that when we think about a future state that, it can't continue to look like it does today, and that there's going to be some pain, in that transition. And I include health plans, in this statement. And then third, going back to the chart on the last slide, would urge policymakers to be mindful that there is the state regulated versus non-state regulated market dynamics, and that be mindful that of policy changes that will continue to drive Vermonters out of the state regulated markets in favor of other options. State law has a limited and shrinking reach on the private pay markets, and any changes that this legislature make really only affect the two local not-for-profit community focused plans at the end of the day. So I think that's a really important principle to be mindful of when we're working to ensure that Vermont has a strong and stable health insurance system. So I'm going to stop sharing now and happy to take any questions. And just real quick on some of the discussion before I spoke, I think prices is huge. I think we have to look at costs. The data that Sarah shared about some of the price differentials between facilities was, I think really important. And, we see it because we're a multi-state plan. I mean, the cost of some of these services just across the border in New York relative to what, we pay in Vermont is dramatically different for the same service. Let's take an MRI, for example, lab services. I think the lack of competition or choice for Vermonters around where they can get some of these services definitely something, to look at and consider as to why the prices might be where they are. And, there was just discussion about prescription drugs, another policy area to be mindful of or to be thinking of when we talk about prescription drugs are medical drugs. So drugs that are administered in a hospital or outpatient facility, those are, have their own kind of unique, pricing features. And, we're seeing pretty significant trends around outpatient prescription drugs being that's where we're seeing some of the highest cost trends in our data around prescription drugs. So those are, a little unique because we're probably going to have a discussion around the 340B program, which, is an important program. It really helps the hospitals, the safety net providers in particular. But, I think it's important to understand to what extent, that plays a role in increasing some of these drugs for the commercial markets. For example, the PBM law that the legislature passed a few years ago, and, this was a head scratcher for me. There's a kind of an unnoticed provision in there that prohibits us or our PBM from even tracking on our claims when a 340B drug is used. So we really have no idea, how much money we're spending on these drugs relative to what acquisition costs are and so forth. So, these are really complicated discussions, but, really important ones given where we are, as a healthcare system.
Senator Thorpe has a question.
That's another general question. We were talking a little bit earlier about the differential in pharmacy pricing between Canada, Quebec, and Vermont. Is there any differentiation in pricing at the retail pharmacy level between New York and Vermont?
The retail pharmacy level, I can't answer that with any level of authority. I'd have to check with our folks.
I want to just send all our residents to Plattsburgh.
Yeah. So in MVP's case, we work with a PBM, and our PBM relationship extends, across our footprint. So I would be surprised if there were significant pricing differentials for our members in our network across border. But, I think the outpatient drug issue is certainly one that's worth exploring as well.
Other questions? Okay, thank you, Jordan. That's been helpful.
Appreciate your time.
We will see you, I'm sure, again before we finish.
Actually, Claire's in the room. She reminded me real quick. Two bills I think are important that we're working on the House with right now. One is the small group individual merged market bill. Like Mike, like Blue Cross, MVP strongly supports that. The other is an Act 111 kind of cleanup bill. We've been working with stakeholders over the course of the summer and the fall since that act was passage to make some clarifying changes. One important change for MVP is, and I don't think anyone envisioned this when the act was being considered, is a limitation on applying the claims edit standards within the act only to Vermont-based providers. So, the way it's written under insurance law, we have a concern that if I'm an MVP member in Vermont and I'm traveling somewhere in New York, because of where it sits under the statute, that would apply to the transaction at Albany Med in Albany. So that would be impossible for a small plan like MVP to ever effectuate. And I don't think that was the legislative intent. So we've had a lot of good discussions, and that is in H31, and we would strongly support, advancement of that as well. So more to come on those bills.
It makes it this way. Okay, thank you.
Thank you.
Thank you, committee. If I find somebody to do it, I'm going to have you have another wonderful day. And we can do PBMs 101.
This is great. Thank you for this.
So this is just background. If Sarah, Mike, anybody knows anyone that does PBMs 101, let me know. The pharmacy benefit managers are another layer. Sometimes they work well, sometimes they don't. I know we've been told don't touch Medicaid drugs because they were very happy with what their PBM got them at the state level. But that it's just another big player as we get into this that we need to have a rudimentary understanding of. By next week, we will have the governor's budget. I think that's on Thursday. Wednesday?
Yeah.
Tuesday? Tuesday.
But he's presenting on Thursday. No, the budget address, Tuesday, I think, or Thursday.
28th.
The 28th. That's Thursday.
No, it's more that.
Tuesday.
It's Tuesday. Okay, so we'll move that down.
Just.
Okay, so we may not get to TBMs until Friday. But we will do a brief, that's, I think, the other big player that we need to know is in this healthcare world. And then, if anybody else has anyone you want to hear from, let me know. Any group, any questions, we'll get that out. I think once we get the governor's budget address, we're going to be really focused on the financing section. I think we may get briefing on, I think that's what we're going to get with the all member caucus this week.
It's all that.
Tomorrow
Yeah.
at 10 is emergency board, I believe. And then we will know what our revenue picture looks like. For the rest,
Anybody can go. to anyone.
Yeah.
It's open to everybody.
yeah, the room is usually full to the governor's ceremonial office. But y'all, this is not the house. Y'all have meetings in the morning. Most of whom only have 5 members. So the chairs react poorly if you're not there. And I won't be there, which pretty much precludes anyone from health and welfare going up. But we will get a briefing in the afternoon from Tom Cavett.
Yeah.
And it will give us, this is the census forecast, so they've arrived at an agreement. I'm told there's nothing earth shattering at this point. But
The board will get it 3 hours before we do.
That's usually why I
I
went.
missed it this morning because I can't get my calendars coordinated. I have 2, one for here and one for everything else. And apparently I'm told they don't play well together. We
Oh, yeah.
haven't been able
What are you
to.
trying to merge? You got Outlook calendar and,
I've tried to get my Outlook and my Google calendar.
oh, that's doable.
Not just see them across pocket.
Yeah, that's doable.
Can we?
No, I've done
Hey, you asked me.
Here you go.
Constantly in real time.
it. Yeah.
See that.
They did it once before and then last year they said, no, they couldn't do it.
Oh, yeah, still.
and it's hard. We can go off live. We are off the
My team's
topic
here.
of today.
This
We
is
are
great.
done.